Here we are. Welcome to London, guys. Welcome to London.
Quite beautiful first MDT session. Did you like it? Raise your flags. Come on, raise your flags. Okay, great. So this was supposed to be a challenging case. This is not, for whoever knows us, this is not going to be a sort of Kama Sutra case from wire from up and down and whatever. This is not the worst ever, but I think it's going to be pretty interesting just to discuss about. So this is a gentleman, 72-year-old gentleman, diabetes mellitus, high blood pressure, or 2 PCIs previously, CPO. And this guy had undergone 2 stenting on both iliacs, common and external. And on the right side, he also had a common femoral endarterectomy and recanalization of the SFA and also BTK staph because the patient had an acute diabetic foot with an abscess, great abscess. So he also underwent 2 amputation. And the chief complaint now is that this 2 amputation 6 months later was not healing well. So this is how it looked. AVI were not compressible. TCTO2 just dropped up to 32 millimeters of mercury. And we perform a duplex ultrasound which underline severe in-stent stenosis.
Can I stop here? Can I stop here? Because I mean, it's something that's going to be tackled tonight by Mark Portu. This is also, I mean, where we probably will lack a little bit. Do you like this amputation? Raise your green flag if you like it, red flag if you don't like it.
Okay, well done. Thank you very much.
No, I mean, it's like, it's something that I always see in presentations, not like nothing to, of course, tackle my good friend, but we need to consider transmetatarsal amputation earlier probably than what we do. Maybe the patient doesn't even come from your center, I don't know. But I think this is not something that's going to last. So I think we need to provide a good, stable foot, and this is where, as vascular community, probably we lack of knowledge, because we need more orthopedic involvement in order to get a better, stable amputation. Sorry, just to raise and also to put a bit of hype for this afternoon when there will be the session, deep dive into the foot with a discussion only about this.
Thank you. So we perform an angio, and as you can see, we still have a stamp of SFA patent, also some patency of the stent itself, and the run-off vessel was a peroneal artery, a sluggish flow at the level of the distal posterior tibial lateral plantar, who knows? This was 3 weeks prior to the procedure. So we took this guy. Oh, let's ask the question. What would you do with this in-stent restenosis? Red flag, would you perform POVA? Reds? No. DCB for the greens, 3, 4. Yellow for scaffolding, cover or uncover. Yellows?
Relining?
Relining, no. What about, well, we only have 3 flags. So for the 4 options, you can do this fancy thing. I've been practicing at home, but Michelle is really great with that. So the bulking, great. Okay, that was also our plan. And we performed an angio, and surprise, surprise, the whole thing had gone. So complete occlusion of the SFA and the stent. And the runoff looked pretty much similar as it was. So at that stage, we decided just to cross the lesion with our Besten catheter, and as you can see, we struggled a little bit initially, but eventually we were able to cross. And look at the wire, it just crossed like smooth and easy. Too smooth, too easy, probably.
Can I stop you 1 second? I mean,
can you
stop the video?
Stop the video.
I think it's important also to get, when you do these pictures,
stop the video, please.
Because there's the complete occlusion of the stent. It's very important to inject 10 milliliters of neat contrast in order to see the distality. Because if you do anything else, we do like 50-50 or 5 millimeters of contrast.
Can you stop the video or get back?
You will never be able to see the distality. And you need to know, if you want to do a bypass, if you want to do an endovascular, if you have some landing zone where to land, and which is the vessel. Can we go back 30 seconds in the video, please? I know it's a bit challenging, but you need to stop when we stop. Because I think it's to visualize what you're doing is the first step before doing any revascularization. Do we all agree?
Okay.
Okay.
So, again, can you just go forward in the clip? No, in the clip itself. Get back. And can you just, with the mouse, yes? Okay.
Just play. Okay, that's
Go
perfect,
ahead.
perfect. So baseline angio, you see the whole SFA is occluded. You see how the contrast is neat here. And it's very important because then when you go to these kind of very tiny vessels, you will never see the peritoneal if you don't inject neat contrast. And even less, you will never see the lateral plantar artery or whatever is left if you don't perform neat contrast. And also, you know,
and it's really important because if you end up with some complications like distal embolization, if you don't perform a distal angio, you will never be aware of what has happened. Okay? So as you see, we were able to cross too nice, too easy.
Yes.
This is a Terumo wire. 035, yeah, in a loop way maneuver. So we progress our...
August, one more.
Just let me finish this clip, and then, because otherwise we're going so we decided just to double check that the wire has crossed nicely. It was not a Terumo wire, it's an 018. So we want to check with our IBUS that the wire has not gone through the stent, so through the structure of the stent. This is not a fresh stent, this is not planted, so it's quite unusual, but it's a good idea just to have a look. But the important information of the IBUS is to see what has happened. Oh, go ahead. Are you playing with my clip?
Go.
No, I have.
Click.
Okay. No, get back.
August, why do you use IBUS in this case? Is clearly that is a thrombus because you pass easily the...
Yeah, because we use IBUS, one, just to double check, we thought there was fresh thrombus there. We had the proof that 3 weeks earlier it was patent, so for sure there was thrombus. But also at the end of the procedure, if you want to check the outcomes of your atherectomy or wherever, the expansion of the stent, the apposition of the stent. So IBUS, you will see later on, provides you with a lot.
At the beginning, what?
Well, if you're going to use the IBUS and you want to record a nice clip for the fellows, use the IBUS. Okay.
I think that in decision making in this patient, it is very important to obtain an X-ray acquisition with high quality in different projection in order to understand if the patient have a stent fracture.
Good
because
point.
in the decision making, change your idea about the treatment for this
yeah,
kind
that's
of...
definitely right. You know that fractures are related to patency. This is a good point.
And especially if you are going to use a Rotarex device or some debulking device. You don't want to go in through the struts and you know.
Okay, we have a double check that we have fresh thrombus inside the stent. So what would you do? Red, you will change your mind and go for open surgery? No? Okay. Green, pharmacotherapy, fibrinolysis. 3. Yellow, the poor man solution, transcatheter aspiration. No? Rich guys. Mechanical thrombectomy? Cool. Let me say that since we were confident to perform an atherectomy, we were dummy enough just to have the device on the table at that stage. So with the device on the table, any one of you would just thought like, okay, let's go ahead with the atherectomy and God knows. No?
Yeah.
1, Michel.
Michel.
Well, it looks like you have the jet stream, if I'm not mistaken.
There it is.
Yeah? So it's also an it's has a suction function as well. So it has not as much as the 8 French Rotarex, which I would use in this case, but it has the same amount of suction as the 6 French Rotarex.
Yeah, it is.
It's expensive.
It has an aspiration port, and which is probably a unique feature compared with other atherectomy devices. But honestly, I don't really want to use it in fresh thrombus. I think it aspirates, but not that much. Anyone would just splash the whole thing? No? Okay.
Because another thing could be also to put a long cover stent. And then, you know, but the thing, like, you can also toothpaste everything into the profonda. You can move it down. I mean, it could be an option, but I personally think it's a bit risky.
Yeah.
You know? If the patient is under local anesthesia and you need to do something quick, maybe it could be an option.
Yeah, those are my reasons. So why I prefer to use mechanical thrombectomy, because it reduces procedural time, which entails have a quick reperfusion. It also helps to reveal your covered lesion. So if you want to stent with a covered stent, you're going to use a short stent rather than a long stent covering the whole thing. Reduces the risk of distal embolization, which is a real issue, these fresh thrombus. And compared with lytic therapy, you save money of ICU, bed, bleeding complications, and also this hospital stay times.
My experience is so that it's essential that we have an embolic protection in such cases. In case you want to make the mechanical thrombectomy, would be also my first choice. But also, if you want to cover the stent with the cover stent or anything else, the risk of embolization in this case is very high, in my opinion.
Especially in a single vessel runoff.
Yeah, that's a point.
Yeah.
My question is about, you will use Rotarex. What about the iliac, common iliac? Because the patient has bilateral common iliac artery stenting. Is it kissing stent?
No,
Because
no,
for
it
the
was not,
Rotarex,
yeah.
when you have a kissing stent, it could be dangerous with rupture of the Rotarex.
But he had an antegrade access. He had an antegrade access.
Yeah.
Antegrade, 8 French, which I also would do.
Yeah.
I mean, I personally would never go for an up and over if you have also to treat
Yeah.
down into the foot.
We always take for granted that occluded stents and grafts are filled with thrombus. I would like to hear your opinion on a personal experience of mine that sometimes we get surprised. They are filled with some sort of fluid, but it's actually not thrombus. It may be occluded and thrombosed at the distal or proximal end, but the length of the occluded graft or stent may be just fluid.
Okay.
Do you
So
share that experience?
thank you for your remark, because this remark answers your question. Why to use Hybel 4? This is the answer. You can just underline a patent graft, which
It's the same
seems
as
to be
chronic total
occluded.
occlusion.
Yeah.
It's never like the chronic total occlusion all occluded. Sometimes it's like spots, and in the middle you see the guide wire moving freely. So it's more or less the same with stents. And I've seen IVUS myself showing this. Yes.
Okay. So, and I rather use angiojet because it helps you just to combine both advantages. You can suck the clot with lytic therapy and then just remove the clot with your aspiration. And also because you can use this device for distal vessels, very distal vessels, even in the plantar arch, which is a nice feature for me. And you may probably think, oh, yeah, but I can just use catheter and just aspirate. And if you have a look to these diagrams, this is the power aspiration of a catheter, the low-cost solution, and this is the one of the angiojet, and you look like this flashed thing, which gives you an idea of what you can get from the device. And as you see the diagrams, this is the amount of residual thrombus you can get if you just aspirate with a low-cost device. Okay, so we also use embolic protection device, just double extra care, and then this is quite an easy plug and play system. As you can see, we just plug the catheter inside the console, and then you just go ahead with your catheter. This clip, by the way, is where's Dr. Carvajal, Rodriguez Carvajal? It's yours. Okay, so we just went ahead with this.
Okay, just for everyone, this is a speed up movie, yeah?
Yeah,
I mean, you don't proceed that quick, yeah?
It's 1 millimeter per second. This is for the sake of time. So we
Just to
just
clarify.
cross 3 times and look what you can get with 3 crosses of your device. Yep.
Raise your flag so I can see you.
Do you
And
use
this
some
is
kind of...
this is the completion. So we just got a nice channel already there.
do you use
Go
some
ahead,
kind
Michel.
of lytic agent inside of your angiojet
Yeah.
volume?
Yeah, we like to soak it and then just go for with the angiojet. Yet it's more time consuming. It's going to take 10.
In the fluid you're using.
Which one? We
For the
use
angiojet.
RTPA.
How much?
How much do you put in
The usual dose. My personal
Minors, no.
so-
Yeah, yeah.
August, is the history of the patient important in the choice of which mechanical thrombectomy device you use?
It's
Sorry?
Is the history of the patient?
Yeah, yeah, yeah.
Of the
You need to be aware with using this device, if you have an impairment of your renal function, if you just suck too much, probably you just can get in trouble. And it's good recommendation is to hydrate a lot the patient after the procedure. Yeah. You mean that?
no, also
Prof?
no. I'm saying like the time of the thrombus. So essentially,
The time, yeah. I would say
Set
that,
of the symptom is very
yeah,
important
I would say that
in the selection.
my algorithm is for fresh thrombus. Probably some of you may be thinking about the Rotarex device. Yeah, that's quite useful. But my algorithm, at least at home, I have both. For fresh thrombus, really fresh thrombus, I like to use the angiojet. For super acute, or like 1 month, 2 months, we have been talking about 3 years treatment, but this is not my experience. And then for already established long ongoing occlusion, I prefer just to do a thoracotomy with my jet stream. So what's the next step? We already got a channel, POVA, the red one. No POVA. DCB. 1. Oh, scaffolding, relining. Fancy debulking DCB. Okay, this was our original plan. So it's quite unusual to see that you have changed your mind, because we are at the starting point where everybody here was aiming to have a thoracotomy and DCB. Why? Go.
I mean, okay, Michel.
Quick question, because we started when you have the jet stream on the table, so of course you're going to do debulking now. But if you didn't have the jet stream on the table and you have a fresh occluded stent, would you do angiojet and then debulking?
I would say so. So the reason, the rationality behind your decision is just the budget. Red is the budget. Just raise the red is yes. Budget issue or not?
Yeah, I mean, of course.
Okay. Okay.
Yeah, just one question. I think the most important question for the patient is the onset of the symptoms.
Yep.
So I think this is the most important reason to choose the best solution, the best tool that you have. So probably not 2 a thoracotomy system, just 1. But if you have 4 weeks, 8 weeks, so it depends.
No, it was the most 3 weeks, because we have a prior angio, which was patent.
So 3 weeks.
3 weeks.
So it is
3 or less.
Yeah, so it is thrombus. So probably
Yeah.
3 weeks, probably some could use also other aspiration
Alf.
device systems.
Of course, there's a
we
mixed
have-
component. Yeah, there's a mixed component, and there's of course the part which is the fresh thrombus, but the fresh thrombus doesn't come on a complete pristine stent. So probably it was not a stent deployed the day before. So I think there's a mix. That's why, I mean, could be like another thing could be the bulking plus DCB. You remove the thrombus and then just to justify, please.
Yes, that's what I was just going to say, because if you have a patent stent 3 weeks earlier, it might have something happen right there. So just making thrombectomy, you're at the point that it's gonna just you know what happened. And just making a decision of what to do next should be related on the next information that you got after making an angio, after you make the thrombectomy. So you may have the bad position of the stent, you may look that it got broke, you may know that you have something that you have to debulking below the stent.
The important thing is that you could have in a restenosis, so fibrosis plus clots.
Yep.
So if you 3 weeks earlier you had a patent stent, so there is just thrombus. So the residual stenosis is not fibrotic, it's thrombus.
No.
This is
Remember that 3 weeks earlier, the stent was almost occluded. Remember the baseline angio? All the stent was almost occluded. We have a patent SFA at tiny
okay.
pieces.
Okay, so
it was a long-standing
so
in-stent
it was
restenosis.
fibrotic.
Yeah.
It was fibrotic.
Okay, let's go ahead.
Another point, from my point of view, another point is, do we have stent fractures or not. If we have fractures, I would go for scaffolding, for
Okay, good
probably
point.
with cover stent or with drug-eluting stent.
Yeah, because
But
if you...
if the stent is all right after vessel prep or whatever.
That's a good point. If you have fractures, you need to reline, and also because of fracture, you have pieces of the struts inside the lumen itself, and you just get trapped with your atherectomy, whatever device. Go ahead.
Another issue would be because nobody voted for catheter aspiration. It's quite reasonable to proceed with aspiration, get the fresh thrombus out because it's very cost effective, and then decide what you do next.
Okay.
Is it possible to do with that amount of thrombus just with the catheter? I mean,
Yes,
you mean
you can-
penumbra, or you mean like
Yeah,
the
you can
catheter,
use
6 French catheter?
8 French or 7 French envoy catheter aspiration, and you can take us out lots of thrombus.
Okay, let me tell you why I'm on the fancy side. Because this is the sort of stuff you have when you have in-stent restenosis. This is from Costas, that's beautiful. So you have this sort of gummy thing inside the stent. You dilate this, nice result, and in a couple of days, again, restenotic. And this has been nicely shown in the Tosaka classification. As you can see, 2 and 3, they have really poor results after PTA. And you may probably think relining. I don't really like relining because if you put layer over layer over layer, at the end of the day, you lose effective lumen gain. It's what we call, for the Italian guys, the lasagna effect. So why not just to gain lumen? And as you can see, there are different atherectomy devices on the market. They all have pros and cons. I prefer to use rotational because it's pretty versatile. You can use it on fibrotic lesions, calcified lesions, even thrombus, not acute thrombus, and also this active aspiration. And also because it's the only one approved for in-stent restenosis, as well as the laser, but in Europe, we hardly ever use laser. And as you can see, you have a front-cutting tip, blades on the sides, different sizes. So we decided to go for the atherectomy. This is a 2.4, 3.4 with the blades up. As you can see, you have the console, you have the port, remote control. The arrow is the active mode. The Rex means aspiration. And the yellow button is just to change from blades up to blades down. So we usually pass through deletion 2 times with blades down, and we usually spare the procedure in 3 portions or 2, depending on the length of the occlusion. And if we have a real occlusion, because this guy was patent, but if we have a complete occlusion, what we like to do is just to keep the distal cap of the lesion just in order to have an extra safe mode, just to retain whatever debris you can originate and then aspirate.
Question, do you have a filter in place?
Sorry? Yeah, we had a filter.
Okay, that's important, guys, yeah? It's from IFU. I think in this case particularly it's important. Single vessel runoff, try to really to minimize the risk of distal embolization.
So is anyone in the audience using any other sort of atherectomy device in in-stent stenosis or occlusion? So, Peter, in the States you use quite a lot the hawks. Do you use the hawks in the stent stenosis?
Adi or Peter?
I just had
Harry, yeah.
I just had a quick comment too. So you used here 2 devices, one thrombectomy device and one atherectomy device, which is great. Even though Jetstream can technically aspirate the thrombus, you could start with that. But there are 2 other devices that are very helpful in this setting. Like a lot of you have mentioned, Rotarex is phenomenal with regards to the thrombectomy aspect, in addition to the atherectomy, plus laser.
Yep.
Laser vaporizes the clot, plus obviously has one of the best data for in-stent occlusion and in-stent restenosis.
Yeah. I always wonder, to be completely honest, laser is super used in the States, but not at all in Europe. Why do you think this happens?
I think it may be reimbursement,
Okay.
but the data is excellent and the use is very simple. You just pass the catheter through the material. There's no learning curve.
Okay, Peter.
Peter, another option from the US?
Yeah, just briefly on lasers, that's my go-to for in-stent restenosis because it vaporizes clot. So you can do atherectomy and thrombectomy at the same time.
Okay.
And we have an an indication in FDA label for
Yeah.
instant restenosis.
And can I ask
which
you, Peter,
most of the
do
devices
you use
do
a
not.
filter with a laser or not at all? Do you use a filter with a laser, APD? Okay.
Yes, every time the wire goes too easy, no matter what kind of lesion, stent, no stent, whatever, wire goes too easy, filter.
Okay. You have skipped the outcome, but probably have you seen the nice outcome following the atherectomy? Nice breeze flow
Craig.
all over the.
August, just to say that instant restenosis is perfect for the hole because when you mag up, you've essentially got a live overlay of your vessel. You don't even need to use angio. You just keep cutting until you come up to the side of the stent, and then you turn and you go the other side, and then you go into orthogonal view. So for me, it's a hole, but then I don't have the experience that these guys have got with laser.
Definitely. So Lorenzo, give me a favor. Will you just go there?
And go out and
no out.
come back.
Not yet. I just try to get to the clip and just to show the completion angio. Just scroll down through the video.
So what do you mean, like the
Just
conventional angio?
to allow people to see the final outcome following the atherectomy.
The one before?
No, this one, but the end of the clip. Just no, that one, and then just scroll on the
This
clip.
one?
Yeah, just use the mouse.
Yeah, but I can't.
Just to go forward.
You can't do that. Okay.
Okay, anyway. Super good outcome, believe me. Okay, so are we done? Do you think that this is enough to end up with complete wound healing of this guy? Yes, red? Not? Green? Yellow, depending on the runoff? Yellow, yeah. Okay, so let me remind you, this is the runoff. We have some stenosis at the P3 segment, also a perineal artery, a tiny DP, and a sluggish lateral plantar. So we performed some DCB on the P3 segment, P2 as well, at dissection, which was sorted out with prolonged inflation pretty nicely. And then we also perform a balloon dilation of the perineal artery. This is the check angio following the dissection, prolonged dilation. This is a coyote balloon. And then we thought that we probably needed just to go for another vessel due to this extensive wound. Can you just jump for the next one, please?
Next.
Oh, here we are. So we went for the posterior tibial. So we crossed nicely with the wire. As you can see, we were able to recanalize, drill. This is a B18 wire. And then we end up in the distal posterior tibial. Pre-dilation with a coyote balloon, 2 millimeters, just to gain room. And then also 3 millimeters. And then we went into the lateral plantar, and we performed our plantar loop maneuver. This is slightly, this is a loop tip, but this was interluminal, of course. And then get into the DP, and then balloon dilation of the arch itself, following pre-dilation with a 2 millimeters balloon. This was a 2.5, if I'm not wrong. And this is the completion angio with nice breeze flow, both in the perineal and also in the lateral plantar and the posterior tibial. And again, see the blush at the level of the wound.
Do you think there's because I mean, that's also important to see, there's a medial plantar which doesn't have a great flow. So that's why it's important also to have an angio before, in order to decide, should I do something more? Should I try, even some lysis into the vessel? I mean, it's very difficult when it's so distal, but it's a difficult case where you need to be prepared. So please take the nice pictures at the beginning. The anteroposterior view of the foot is super important in this case, because if you don't do that, you will never know if we can do something more, even just trying to inject some RTPA, I think.
Okay, so this is the clinical outcome. The guy was discharged the day after, 2 months later, this wear amputation was completely healed. So, take-home messages. They look alike. 4 legs, horsehair, a tail, but thrombectomy devices has nothing to do with atherectomy devices. This is a really important message. Don't use atherectomy devices in acute thrombus because you splash the sheath downwards. And you may end up having a distal embolization, which turns a claudican into a limb-threatening limb. This is super important. And don't try to use a thrombectomy device to deal with calcium, because this is not designed for. Sometimes we hear about like, oh, this atherectomy device, this is not for calcium. This is a really important message as well. So vessel prep is really important wherever you use. Atherectomy is feasible for, as you have seen, in stent stenosis or occlusion, and for plaque modification, because if you perform atherectomy, you change the compliance, which allows you to perform an angioplasty not super aggressive, decreasing the risk of dissection, and bailout stenting, and also plaque modifications allows you to have a better uptake of the drugs if you're using drug technology. Dedicated devices, as you have seen, can save your days. And please stop believing and start knowing, because if you see what's going on, it's a lot better and you will get better outcomes. So thank you very much for your attention.